Well, good afternoon, everyone. It's noontime, time for Northeastern at noon. Welcome to see you all here. And today's topic is going to be what the United States can learn from healthcare delivery in India. Kind of an interesting take on reverse engineering. What are other people doing? How do they do it? Why does it work? And can we apply it to anything that we're doing? And it reminds me of some experiences that I've had working for Raytheon for 40 years. We had occasion to have access to foreign military equipment, some of it from second and third world countries. And all these devices had some limitations and vulnerabilities. What my main takeaway was that they were simple, and perhaps even more impressive, they were remarkably clever. So it made me appreciate how there is a lot of knowledge, not only throughout our country, but throughout the planet as a whole. Many other people are just as clever as us. And it's maybe time that we paid more attention to this. And to tell us all about this, our speaker today, Ravi Ramamurti, is an expert on strategy and innovation in emerging markets. Here at Northeastern, he is University Distinguished Professor of International Business and Strategy. And incidentally, University Distinguished Professorship is the highest honor bestowed on faculty here at Northeastern. He's also the founding director of the Center of Emerging Markets at Northeastern. Ravi, as he is known, obtained his Bachelor of Science in Physics from Delhi University, his MBA from the Indian Institute of Management, where he received the gold medal for graduating first in his class. And he went on to get a doctorate in business administration from that school across the river. I think it's Harvard Business School, where he just happened to be awarded their dissertation fellowship. Besides Northeastern University, he has been a visiting professor of business administration at the Harvard Business School, at the Wharton School of the University of Pennsylvania, and the MIT Sloan School of Management. He's also taught at Tufts University's Fletcher School, the China-Europe International Business School in Shanghai, and the IMD Switzerland. Prior to academia, he worked as a consultant to the Indian Planning Commission, also as an executive assistant to the CEO of India's largest engineering company, as well as being a United Nations advisor to Bangladesh and South Korea. For his, quote, outstanding contributions to the scholarly development of international business, close quote, he was elected a Fellow of the Academy of International Business in 2008. A survey ranked him among the top 1% of all scholars in his field. He is the author of 8 books, including 3 published by the Cambridge University Press and 1 by Harvard Business Review Press. He was elected in 2007 as president of the Academy of Management's International Management Division. In 2017, the Globals, based out of London, named him the most innovative thinker on strategy and innovation in emerging markets in the world. He's a 6-time winner of the ADL Prize for Professor of the Year based on his teaching. Well, I could go on more. I have more stuff. However, I think you get the idea that we are very privileged to have with us such a distinguished presenter today. And so, without further ado, I turn it over to our presenter.
Thank you. Thank you, Joe. Hello, everyone. Nice to be here, and also hello to our online audience. So I'm going to talk today about a particular example of reverse innovation. In this case, we're going to look at can we learn anything from healthcare delivery practices in a developing country like India, where I'm originally from? And can any of those practices, if there are any good ideas or practices, can we apply them in the US context? Now, I think we all know that the healthcare system in the US has a lot of problems. Basically, we are on an unsustainable path. We have been on an unsustainable path, and we continue to be on an unsustainable path because it just consumes too much of our national resources. We spend $4.8 trillion on healthcare, which is about $14,000 per person, and that's roughly twice as much as other developed countries. So it's not as if everyone is spending at these levels. It consumes 18% of our GDP and expected to go up to 20% of GDP by 2035. It means a fifth of our GDP will be on healthcare. And of course, the costs of healthcare are then transferred into every other industry in which the US tries to compete. So our competitiveness in many industries is hurt by the fact that our healthcare costs are as high as they are. Someone estimated the average car carries about $2,000 to $3,000 of healthcare costs, benefits provided to the people who produce these cars. So it affects every industry in which we compete. And despite all of the spending, we have 27 million people who are uninsured and many more who are underinsured. And that's about 8 to 10% of our population. So despite all the spending, we don't have universal access yet. And the outcomes, the medical outcomes, are also not much better than that of other developed or wealthy economies. In fact, in some measures, we are somewhere at the bottom. If you look at this chart, and it's kind of hard to see, the blue dot represents the US, and the top is the best and the bottom is the worst. So on several indicators, including life expectancy, infant mortality, and so on, we are not anywhere near the top where we should be given the amount we're spending. So the challenge, and this has been with us for a long time, is how do we lower costs, how do we improve access, and how do we maintain or improve quality, right? So these are the three main objectives of the healthcare system. Now, to look for ideas to answer this question, we decided to look at the case of India. So let me just say a word about why we decided to look at a country like India. The problem in healthcare is that we have third-party payment covering most of the costs. So we are insured. For good reason, we have an insurance system because individuals couldn't take the hit on their own. So we have a system in which we pay a premium, and then if some bad things happen, the insurance covers the cost of treatment. But the trouble with that system is everyone keeps passing the buck, and you all know this very well. Each of us thinks that I'm not paying for it, I can pass it on to somebody else. I don't care what it costs. And of course, at the end of the day, we all end up paying for it. And wages don't rise as much as they would because the benefits eat up all the capacity of employers to pay salaries and benefits. So to get out of this, we really can't look for lessons from many other developed countries because they all have the same issues. You have insurance coverage for healthcare in all of the wealthy countries. So the reason to look for India, places like India, is threefold. First, there's a very large population in India, but a very poor population. On average, per capita income is $3,000. In the US, our per capita income is $75,000. But more important, 90% of the population is uninsured. Whereas I just showed you, US, 90% is insured, 10% is not insured. But in India and countries like India, most people are not insured. That means they pay out of pocket for healthcare. And therefore, the healthcare industry operates like many other industries where consumers look for value. And they have to make really tough choices. Do I really need to have this treatment? Can I afford this treatment? And a lot of people, in fact, don't get the treatment they definitely need because they cannot afford it. But that's the context. And coupled with that, you have a severe shortage of medical professionals and medical facilities. Now, this is all bad news, really, for the country, because you don't have enough doctors, hospitals, people don't have capacity to pay, people are not insured, and you got 400 billion people. The good news here, though, is any hospital or any entrepreneur who wants to provide care to more people, seeing the suffering and so on, because it's in your face when you go to these countries, they have to be really innovative in how they use the scarce supply of doctors, scarce supply of equipment, and make things affordable, ultra affordable for a population that very often goes bankrupt when somebody falls sick in the family, where they have to borrow sometimes for treatment. Many of them do. Or they have to sell all their assets, whatever they own, but a land or a house or any other property or jewelry, in order to pay for healthcare. So it's ripe for healthcare delivery innovation. Now, I said, some of the problems, I pointed out some of the problems in the US healthcare system. Those problems are mainly with healthcare delivery and the cost of healthcare delivery. It's not about medical science. It's not about the innovations in medical devices, innovations in drugs. The US is very good at all that. We come up with some of the latest drugs, the best devices. But the problem is no one pays attention to cost, right? So if you want to improve healthcare delivery, you need to look to places where they are really under much more pressure to innovate. So that's the reason we look at India. And we looked at a handful of hospitals that were doing some very innovative things. This is not to say the whole Indian system is fantastic. In fact, it's pretty awful. A lot of the hospitals are, in pursuit of profit or providing poor quality care and exploiting sick people and their families and so on. So this is not saying India has a solution. It's saying there are some innovative hospitals led by some very innovative, compassionate entrepreneurs who happen also to be doctors in many cases, who have found clever ways, as you said, to deal with the challenges of providing as much care as possible to as many people at the lowest possible price. So here's some prices for some procedures in India, just to give an idea. The open heart surgery for bypass. Sticker price is $3,000 in the hospital that we studied. Their cost is $2,000. And their goal is to bring it down to $800, because even $2,000 is too much. When per capita income is $3,000, you can't charge, even a few $1,000s because it's too much. Cataract surgery, $100 to $200. Cost, $40 to $50. I say, if cost is $50, why is the price $200? Because this hospital provides care to two free patients for every paying patient. So they make enough on the one paying patient to cover all of the out-of-pocket costs of providing cataract surgery to two non-paying patients, and so on. So the prices are typically 1% to 5%, maybe at most 10% of the prices in the US. Now, they're not just cheap because of cheaper labor, because this is the first thing that would come to mind is, per capita income is $3,000, everybody's getting paid a fraction of what we pay them in the US. No surprise, the costs are lower. That is true only for certain kinds of occupations. Administrative staff are much, much cheaper. But doctors are not all that much cheaper, because good doctors can leave the country and go work in the Middle East, work in Singapore, go to London, go to the US. In fact, chances are, if you go to see a random doctor in the US, it's a person who came from India. You've probably encountered that, right? So these doctors are not exactly stuck in India. They are mobile. They're part of what we call a global labor market. They're not part of just a national or a local labor market. So it's not entirely because labor is cheaper. It's not because the quality is bad. In these hospitals, it's not as if you go for open heart surgery in this hospital that will charge you $3,000, you have a 50% chance of making it. No. Your chances of coming out without medical complications, without mortality after 30 days after a procedure, is comparable to that of the best hospitals in the US. In the eye care hospital, the outcomes are as good as those of the UK medical system. So it's not as, in these hospitals, the quality is actually very comparable to what we have in the US. And despite these low prices and comparable quality, and despite giving away their services for subsidized patients to the extent of 20 to 50% of their patients, the hospitals are profitable. Okay? Because most of the hospitals we studied are private hospitals. They are, in fact, some of them are for-profit, some of them are not for-profit. That doesn't seem to matter, because if you're for-profit, there's still the ones we looked at are for-profit because that's the way they think they can scale up. If they don't have that model, they cannot scale up. And those who are not for-profit, of course, you could say their heart is in the right place, but they run their business as if it's a business, because they understand that unless they run it very efficiently, they cannot serve more people. So the goal of these organizations, as I like to think of it, is they are not profit maximizers, they are not revenue maximizers, they are not market share maximizers. They are what I like to call reach maximizers. Their goal is to touch as many people as they can. That's the goal, but to do it in a sustainable way, financially sustainable way. And as a result, they are able to provide low cost, high quality, and broaden the access of their services. Now, we wrote up all of this, and I've circulated for you the copy of the Harvard Business Review article and then the more recent book. We had another one in Harvard Business Review after we wrote the book. But what I want to do now is really get to the question, how do they do it? And of course, then we'd be curious about how can we bring any of those practices to the US? And of course, that's a very tough thing to talk through. So the way they do it, in a nutshell, is they leverage the power of volume, they leverage the power of process, and they leverage the power of purpose. This, if I had to boil it down, I would say these are the three things. And I think the best way to understand this is to look at one example. So I'm going to show you does this have internet connection? Yes. Okay. So I want to show you like 5 to 6 minutes or maybe 7 minutes of a clip on one of these hospitals. This is the eye care hospital. But you could tell similar stories about the heart hospital or the cancer hospital or the orthopedic hospital and so on. Now let's see if this works.
Worldwide, 285 million people are blind or visually impaired. 80% of that blindness is avoidable. A simple operation can restore sight. But for many, the cost of treatment is simply too high. Here in South India, in a city called Madurai, Aravind has been working to turn those economics around. When people walk into an Aravind eye hospital, they have a choice, whether to pay for treatment or to receive it for free.
The vision and the mission of Aravind is to eliminate needless blindness. Anybody can walk in, whether he's a rich or a poor, educated or uneducated, anybody will be treated in the same way with dignity.
No one is turned away, and patients do not have to wait for treatment.
Aravind does not work on an appointment system. Whoever comes across gets seen on that day. We never make a patient wait or come again for things that can be done on the same day.
Collectively, Aravind's network of hospitals see over 12,000 patients and perform 1,500 operations each day. The quality of treatment is the same for both paying and free patients. In this model, revenue from each paying patient supports treatment for 2 free surgeries. Aravind does not depend on donations or government support. Patient income funds all its growth and expansion. Their mission is to make the highest quality eye care available to anyone who needs it, rich or poor. Today, a streamlined workflow, rigorous systems, and a mindset of frugality enable Aravind to perform over 200,000 free surgeries each year.
It should be affordable to everyone. Everyone who has eyes must have a sight.
When Aravind first opened its doors and offered free service, it discovered another barrier to access. Many patients lived in rural settings, far away from a hospital. They could not afford the cost of the journey. Since these patients could not come to Aravind, Aravind went to them. A series of eye camps were launched in rural areas.
The camp is basically an outreach program. So we come to the places which are not easily accessible. We do a screening for them, and the patients that require surgery, we'll take them back to the base hospital, do a surgery free of cost, and bring them back here.
This woman has a cataract in her left eye.
கீழே பாருங்கம்மா, நம்ம போற ரொம்ப இருக்கு, சரியா? அதனால பின்னாடி நரம்பு எப்படி இருக்குன்னு இப்ப சொல்ல முடியாது.
களவட்ட போனாரு, காய் கஷ்டப்பட்டு போனாரு, அது நடுவில் வேலை செஞ்சால் தானே வாங்குவாங்க. ஒரு காட்டுக்கே போனாரு, திருப்பி போட்டு விட்டுருவோம். அது அப்புறம் கொஞ்சம் மங்களம் தெரியுதுங்கள, இருட்டாகிட்டா கொஞ்சம் தடுமாறிக்கிட்டு விழுந்துட்டு என்ன பண்ணுறதுன்னு வீட்டுக்கு வந்தார்.
சரியா? அப்ப அந்த கண்ணு பண்ண மாதிரி எல்லாம் இந்த கண்ணு இப்போ அந்த கண்ணு இப்போ கொஞ்சம் தான் இருந்தது, இந்த கண்ணு இப்போ ஜாஸ்தி இருக்கு.
She is one of 200 people from this village whom Aravind will bus back to the main hospital for surgery, where they will receive food, lodging, treatment, return transport, and follow-up care completely free of charge.
காசு வேணுங்கிற கதை கட்டி பண்ணுறது, அதனால இலவசமாக பண்ணுறது அது வழி.
Today, Aravind sees over 3 million people every year, but it started from very humble beginnings. The driving force behind it was Dr. Govindappa Venkataswamy, an ophthalmologist fueled by a compassionate vision.
He set out to cure blindness, not just in his own town or the state of Tamil Nadu, but for the entire world.
Here was a man who was able to look beyond the national boundaries, the religious boundaries, and look at every person and said, why should anyone be blind in this world?
In his early 30s, Dr. V, as he was known, contracted rheumatoid arthritis, a lifelong condition that left his fingers permanently crippled.
That experience gave him a feeling of a patient. Fear, depression, anxiety, pain, looking for somebody with a smile, longing for somebody with a smile. All those things he experienced.
Despite this illness, Dr. V trained as an eye surgeon and went on to personally perform over 100,000 operations. At the age of 58, Dr. V retired as a government ophthalmologist. With his brothers and sisters, he opened an 11-bed eye clinic called Aravind to continue his work. They followed 3 simple principles. We won't turn anyone away. We won't compromise on quality. We must be self-reliant.
Dr. B had this phenomenal vision. He was able to think 20, 30, 40 years in advance when he had a 11-bedded clinic.
India is a country of over 1 billion people with less than 20,000 ophthalmologists. Dr. V knew the scale of the problem demanded a solution of appropriate magnitude. It called for the development of highly efficient systems. 40 years later, his 11-bed eye clinic is now the largest provider of eye care in the world.
எந்த கண்ணு ஆப்ரேஷன்? சரி.
Optimization of workflow, particularly in the operating theatre, has revolutionized the number of surgeries performed.
One of the ways which continues to work very well is for each surgeon to have 2 surgical tables. The surgeon sits in the center and is able to operate upon one patient, whereas the second patient gets prepared by a support team.
When one cataract surgery is complete, the surgeon just moves across to the next cataract table. The time between surgeries is greatly reduced, and the surgeon goes from performing 1 surgery per hour to about 7 or 8 per hour.
This way, a typical surgeon at Aravind is able to perform between 1,500 and 2,000 operations a year, against a national average of 400. In 2015, Aravind treated close to 4 million patients and performed over 400,000 operations at a fraction of what it would cost in other countries. And yet, their clinical outcomes meet or exceed those of hospitals in the West.
Good girl.
So I'm sure you, as Gina was saying, she has questions. I'm sure a lot of things are going through your mind. You're probably cringing when you saw some of the procedures that they're using, the practices that they're following. The techniques they use cannot all be used. Obviously, you can't have 2 patients in the same operating theater in the US, but they do, and so on. That's just the beginning of it. But in terms of outcomes, they're finding for these procedures, that's sufficient. And certainly this model, I think, is certainly very relevant for other developing countries, because they could not use our system and ever provide care for their population. If we spent in India spent on healthcare the way we spend in the US, it would take about 4 or 5 times the total GDP of the whole country, right? So we're at 20% of GDP, and that's not affordable. So other countries have to find other ways. But let's look at the logic of how they're able to bring down the cost, and then I will stop and invite your comments and questions. So I mentioned the power of volume as an important factor, and I think this picture conveys that, and you saw it in the video, just how many people they have. But what many of the other hospitals, including Aravind, as it has evolved, have done is they create a network of what we call hub and spoke. The hubs are where they have the most fancy equipment and the most fancy skills. And in the spokes, as you go down, sometimes there are different many levels of spoke to hub to another spoke and so on. So starting with the village, going to the small towns, to the big towns, to the big cities, the amount of equipment, the amount of expertise, all of which is very scarce, is carefully positioned in these different locations. And each of them is fully utilized to the max. So it's not just that you have volume, but you have to feed the volume, gather the volume, and send it to the right places at the right time to really get the scale economies that these hospitals are able to get. We actually do 5 times as many open heart surgeries in the US as we do in India, but we do them in so many hospitals that no hospital does anywhere close to the number of surgeries that you see in the hospital we looked at in India. Right? So the limited number of cases that the country is able to provide care for is concentrated in the right places. And the hubs and spokes are connected by telecommunication links. And this has been going on long before we talked of telehealth in the US. Telehealth in the US really only picked up after COVID. But India has been, and these hospitals have been using telecommunication links between spokes and hubs, where you can send images back and forth, information back and forth, consult doctors on video conference and so on, for much, much longer than we have in the US. And that because they see technology as a very important friend of the poor. You know, as someone said, one of the doctors told me, technology is a nice thing to have for the rich, but it's absolutely essential for the poor, because without the benefit of technology, they don't have any chance of getting access to the skills or the facilities. So in this example of cancer care, you know, you can see in the map, the big dots, red dots are where the hubs are, and they have a lot of other hospitals that are spokes. In the hub, you would have all the fancy equipment, like the cyclotron or PET scanner and the cyber knife and so on. And then you would use telemedicine to do radiation planning. But the radiation itself could be administered in a spoke. But the radiation oncologists, who are very, very scarce, are located in the big cities. But through the telecommunication links, they can do the planning here, but the treatment can be provided closer to where the patient lives. Now, what the volume does, very obvious thing, is lowers cost. But it lowers costs for all these different reasons. You focus on a few things, like that doctor is only doing cataract surgery. Other types of eye complications will be done in the afternoon. But in the mornings, 7 a.m. to whatever, 11 o'clock, 12 o'clock, it's only so like a factory. And you saw it's like an assembly line, right? You're just moving back and forth. And the other principle they follow is to get the most productivity of the doctors, because doctors are scarce, but also productivity of the equipment. One of the founding doctors told me, we have to make the equipment sweat, not just the doctor sweat. So an MRI will be used almost 24/7. They will do 4 times or 5 times as many scans as we do in the US with an MRI machine. And you don't have a fancier MRI machine than you need. So use the fanciest ones where you absolutely need the fanciest versions, but the less fancy versions can suffice for other settings. And as an equipment gets outdated, instead of being thrown away, it might go from a hub to a spoke. So a spoke that didn't have an MRI machine may now have a less sophisticated MRI machine than the hub, but more than anything it ever had before. What's surprising is the volume also improves quality. In healthcare, in surgery and medical processes, volume improves quality because practice makes perfect. So that doctor who's only doing cataracts, after a while, that doctor has seen every type of cataract and every type of patient. It also helps to attract talent. Because if you're a young doctor, the reason you go to urban, even though you may not make more money, because they don't pay you more if you do more procedures. They pay you a salary, and you work like this, and you're doing 3 or 4 times as many surgeries as doctors working in other eye hospitals, but you're getting experience. And you may leave after a while and go somewhere else, but that experience helps to attract talent. It also leads to medical innovations. Because when you have a tremendous pressure to lower cost, and everybody in the organization understands that we're lowering costs not so that the founder is going to get rich, but because we can then provide surgery to one more patient, everybody is involved in looking for ways to save expenses. So, to give you just one example from Arvind, they used to have to put the artificial lens after you remove the cataract lens. And those initially would cost $100 to $200, and they were imported from the West. Today, they make them in their own factories for $2 a piece. That's how you can bring down the cost for the entire procedure, including the replacement lens, to $40 or $50. Now, you can also get the fancier versions that do all kinds of other things. If you're a rich patient, you can opt for that. But of course, they'll take the profit from that and use that to provide care for non-paying patients. The other thing that happens when you have volume is you begin, even rare conditions, you see much more often. Right? If something happens in 1% of cases, in urban that could be, 10,000? Or is it 1,000 cases in a year? Right? 1% of I think they do 400,000 surgeries, so 1% would be 4,000 cases. So I could be an expert on a rare condition and get a lot of volume even in the rare conditions. So after a while, people want to go to urban because they know there's a doctor there who specializes in this rare condition. So if you or your family member has that condition, you want to go to urban. That's how they became, for instance, the world's leading player in pediatric open heart surgery. This I'm not referring to the heart hospital. They have like a 60-bed ICU for just pediatric open heart surgery. And people come to them from all over the world. from many from the Middle East and Africa and so on, because they have built that expertise in that particular type of condition. Okay, what is the power of process? I think you saw a bit of it in there. That's an extreme version of it. But the principles are, one is called task shifting, which is to make sure that no one does any work that is below their skill level, and no one does any work that is above their skill level. So you try to finely match the expertise with the task. And you don't let doctors, we were just talking before the session began, that you said your primary care doctor was delayed because he was talking to the insurance company about a patient. See, but that's not a doctor should not be, and certainly in India, they couldn't afford to have a doctor waste time doing that. So what they do, if you saw in the video, a doctor is surrounded by 8 support personnel, so that the doctor is only doing surgery, not preparing patients, not putting medicines, not taking them, helping them, not talking to them. All of that is done by the nursing staff, who are actually not even real nurses. Some of them are paramedics. And they're hired from the villages from where their patients come. And the patients like that because these nurses don't talk down to their patients because they're from the same communities. And it gives them a chance to build a skill and maybe pursue a career, because otherwise in the villages they're expected to get married and then stop working. So it also has some other social benefits. And then they develop protocols, and like we do, if you fly an airplane, there's a very strict protocols. We go through step by step to reduce errors, reduce readmissions, reduce medical complications, reduce medical infections, and so on. So these improvements not only lower costs, but they improve quality. This is what we kept finding, that a lot of the things that they would do to lower cost would improve quality, or the things they would do to improve quality would also lower cost. And this is not a novel idea. This is exactly what Toyota showed us in manufacturing. Right? After Ford built the assembly line and showed you could do things a lot faster and a lot more cheaply, but at the end of the line, you still had 20% rework, which is better than 100% rework, which is what the old method was, individual craftsmen building individual cars. So he brought that down to 20%. Toyota brought that down to 0.0001% and said you can have both lower cost and higher quality. In fact, you have to have higher quality if you want to have lower cost. Right? Because if you have to rework, that's cost. So lower quality leads to higher cost. So the way to get quality up and cost down is that there's no conflict here. It's just fixing the process. And I think of these hospitals as the Fords and Toyotas of healthcare delivery. They're hidden somewhere. You've never heard of them. You probably will never hear of them. But they have already cracked the code on how to provide healthcare high quality at very, very low cost. So this is an example of how they support their doctors. Whereas in a typical hospital, a doctor would have one table and one nurse and one set of instruments. What Arvind does is give them multiple nurses and multiple instrument sets and increase the productivity of the doctors. The last thing is the power of purpose, and I think that's where the video helps. You saw the founder of the hospital and his motivation. It's a very inspiring purpose. When you say our goal is to end needless blindness, not only in my village, not only in my city, not only in my state, not only in my country, but on the planet. And they actually have worked with 300 hospitals from around the world. Just like companies go to Toyota to understand how to do manufacturing. Eye hospitals from around the world, including the US, visit Arvind to understand how they do it and see if there is something that they can borrow. And that's the reason why we wrote the book, because we figured maybe there is something here that the rest of the world, not even forget the rest of the world, the rest of India could learn. Because even Indians, hospitals are not paying enough attention to the lessons that a hospital like Arvind or Narayana Health and so on have to offer. So the power of purpose was interesting in these cases because every one of these hospitals, and these are just faces, This is the eye doctor on the left, and the others are, in different medical conditions. They were all doctors, and we call them doctorpreneurs. Because they're like 1/3 doctors, so that leads to medical excellence. They're 1/3 entrepreneurs, that's why the business mindset. They run their operations very, very efficiently with an eye on costs and surplus or profits. And 1/3 is really a philanthropist because they have that compassion to make a difference and bring the medical care to the greatest number of people. And the strategy of serving the rich and the poor forces them to both advance quality, because the rich will not come to your hospital if you don't give them good quality care, because they can afford to go somewhere else where they can get high quality service. But you cannot afford to serve the poor unless you get your costs down. So by deliberately seeking to serve the rich and be able to use some of their surplus to serve the poor, you really have to innovate in your healthcare delivery to get your costs down, because your prices are determined by the market. You can't just charge whatever you want of the rich. Your margins on serving each rich patient must be much higher than that of other hospitals in India, not higher than hospitals in the US, but higher than any hospital in India, that you can afford to cover the costs of patients who can't afford to pay. And out of that purpose also comes a frugal mindset, and I think you saw the reference to that in the video, but you see that in all of these hospitals. They avoid waste, they reuse things that we throw away, single use. There's a clamp used in open heart surgery that costs like $200 a clamp. In the US, it's recommended as single use, so you use it, throw it away. The doctors there say there's no reason to throw it away. You can sterilize and reuse it like we use many other instruments in surgery. They were also soaking in blood, but we wash them, sterilize them. There's a procedure you have to follow. And these procedures, by the way, for these hospitals, many of them are also accredited with what is called the Joint Commission, which is the US accrediting organization. They have an international arm of that, where will look at hospitals outside the US. So they reuse a lot of things safely. When the company found out, the private company selling these clamps found out that they were reusing it, they changed the material for the plastic parts so that when you sterilized it, they would fall apart, so that they couldn't reuse it. Well, these guys, it's cat and mouse, right? They're playing cat and mouse. So they just found suppliers to make just the plastic parts. They would sterilize the rest, put the new plastic parts, and reuse them, and continue to save on that item. They substitute expensive inputs for cheaper inputs by locally designing them, like the intraocular lens that I talked about. They employ doctors typically on payroll, on a fixed salary, no incentives for unnecessary procedures. Fixed price. When you walk in, you know what the price is going to be for your procedure. It's a complete package price. It'll cover everything from medicines to hospital stay to medical treatment. Any complications, everything is covered in that one price. And they also teach their doctors to think about and worry about the costs of anything that they prescribe. One of the doctors told me that the most expensive instrument they have in their hospital is the doctor's pen. Because when the doctor just says, "Oh, go do this procedure," suddenly that could add lots of cost. So they get the doctors also to think about the value of any particular procedure. And the frugal mindset applies to both operating expense, capital expense, the way they build the hospitals, how much medical space versus non-medical space, how they reuse their equipment, how they maintain the equipment. They double the length of the MRI machines compared to US hospitals. And again, the argument that one doctor came to me was, he said, if you can fly a jumbo jet for 40 years or 30 years, why can't you use an MRI for 20 years? Right? It's just all about maintenance. Okay. So what does all this mean for the US? I think in the US we have the volume, but spread it across too many hospitals. We have too many hubs and too many spokes or wannabe hubs. They all want to upgrade. And of course, it's nice when your local hospital has everything you need, but it comes with a cost. It's like saying, if you had a choice to go first class or coach, what would you prefer? I think we'd all prefer first class. But when we fly, we don't all go first class. Some people go first class, some people go business, some people go coach. And most of the plane is coach. But in healthcare, our model is everybody goes first class, which is nice, but it's very expensive. We think of the process still too much as healthcare, surgery as a craft, but that's also again expensive. So if you made cars the way we treat patients, cars would cost $1 million, so to speak, right? So how can we change the process without people feeling somehow that they're sitting on an assembly line? It's not, one doctor cuts you, then you move, another doctor does something on us. That's kind of crass. That's something that we would all be uncomfortable with. They use the facilities fully. The machines here don't sweat enough. There's a lot of idle time in use of facilities, operating theaters, between surgeries, not just the amount of time for a procedure, but how much time is between patients being treated. Task shifting. Doctors spend 50% of their time on non-medical work. And when every time there's a cost problem, we cut the administrative staff, which means the doctors are doing even more of the things they shouldn't be doing. And purpose, I think somewhere this, lost. You said that your doctor said that he wants to stop practicing and go to something else. People with good, similar sentiment may have joined the healthcare field, but they're really very frustrated, many of them, saying, this is not why I became a doctor, to do this sort of thing. So there's a lot of alienation of medical professionals in the US. And I think we don't have anything like a frugal mindset. I think our hospitals are much too luxurious. They look like 7-star hotels. They're better than many hotels we stay in. And all of that, of course, adds to the cost. So anyway, I'm going to stop here. I know we run out of time. But, open to any comments, questions? Yes.
You said you set fixed prices for the procedure. What happens when they get into the working and they open somebody up?
Yeah.
Excuse me. And they think, oh my gosh, this isn't what we thought we had, and you're telling me they don't charge the patient anymore.
Correct.
But ultimately, if that happens many, many times, you'd either have to raise your across-the-board price or I don't know what.
Yeah, you would have to raise the average price you charge for that type of procedure. So they're factoring all of that into their cost. The chance that some percentage of these cases will be complicated, will have complications we haven't anticipated, but we're not going to get into this keeping track of, you consumed one tablet, you took one injection, you had one more test, so now here's your bill itemized. That also has a cost. To list everything and track everything that way also has a cost. And so in other words, they're taking that risk. Whereas here we pass it on to the patient or the insurance company. There they're taking that risk. But if you do enough of these, after a while, I think it averages out. So they know what the average cost is.
Thank you.
Yeah.
I guess another question I have about that situation is, I understand about what they do with the costs, but what do they do to handle the problem if the doctor at hand is specialized to only what they thought it was going to be originally? Are there other doctors in other areas of the center?
Okay. I don't know specific. I can't think of an example that I talked to them about of that situation, but they do have a large pool of doctors. Again, because of the volume, you have a lot of people around. That doesn't mean they're all in the theater at any given time, but they are able to call on. I would assume they're able to call on someone.
Probably the same thing happens here.
Yeah.
You have to get a different doctor.
Correct. That'd be my guess. Yeah.
In terms of the economics of funding, if I'm a doctorpreneur,
Yeah.
how am I building these facilities? Do I get any government? Does the government participate?
Yeah.
Not on the insurance side, because people are so many are uninsured, but do they help subsidize the infrastructure?
Yeah,
In
each-
some way, or is it all privately funded and therefore privately raised?
Yeah, each one has a slightly different story. In the case of Arvind, when you saw that house where he started the hospital, there's an interesting story. Before he started the hospital, after he retired from working for the government, he thought he would go raise money from rich people. He spent a weekend going to a city where there are a lot of rich people. And he went around and he came back with not a whole lot of money. And so he said, you know what, if it's asking people for money, if I had just done surgeries over the weekend, I could have raised, for paying patients, I could have raised more money than I did by begging for help. So when he started it, those 11 beds, they were all paying patients, no free patients. But then as he started accumulating paying patients, he could add beds, more beds for non-paying patients. And that's how they eventually grew to this, have 2 non-paying patients for every paying patient. So it's entirely self-funded. Remember, that was one of the 3 principles they talked about. But not every hospital, cataract surgery is a relatively simple procedure. Open heart surgery is not. So that doctor had to he got some support from his in-laws who were affluent. So they donated some land to initially build the hospital and the building. And then he raised money from private equity, believe it or not. And the private equity investors believed that this model could actually make money. It didn't make money as quickly as they wanted, so they bailed out. So then he did a public listing on the stock market. And the valuation was like $1 billion, which is a lot in the Indian context. And they're very careful about how they commit to non-paying patients. And he is willing to take government help. This hospital was not. But he was willing to take the help of non-profits like the Lions Club. So when they did outreach to the communities to find people and give them, checkups to screen who should be given additional care, they would use the Lions Club or the Rotary Club. They would use the bus with the equipment would be donated by some rich person. So they were willing to take some charity, and they were willing also to use government support if it was available. For instance, hub and spoke for the heart hospital, the spokes in many cases were in government hospitals in the rural areas, but they didn't have the expertise or the equipment. So they would, in that location, put one of their monitors connected by satellite to their central facility and leverage the location and the assets, the buildings and so on. So they didn't have to set up a new facility. So he was much more creative in tapping into all these different resources. But his favorite saying is that charity is not scalable. They all believe that charity is not scalable. And this is, I think, one of the lessons I took away from these examples is they have what I call a social heart and a business mind. This, it's not enough just to have social. A lot of people, NGOs, have a social heart. They have heart is in the right place. They want to do the right thing, but they think business is a bad word, and I shouldn't think of my thing like as a business. But all of these, including this eye doctor, understood that cash in, cash out. You got to manage that, and you got to think of process and think of how you do things, and find ways to economize. And therefore, you can start to scale it up without having to rely entirely on somebody, either government or rich people, to give you charity. But he would accept it. And some of them were, like they returned from the US. The cancer hospital was started by a guy who was practicing MD Anderson. So he was a very reputable training in the US and worked in MD Anderson. And his wife was also a doctor. They made good money in the US. They were able to use that to go back and then, combine with other doctors and start a cancer hospital that then expanded in this fashion. But their goal of all of these founders was, I want to get more people through. I want to make this available to more people. That's the difference between these entrepreneurs and some of the other entrepreneurs. There are lots of entrepreneurs who have also made a lot of money building hospitals for the rich. They're very nice, they're very fancy, they have the latest equipment, they have good doctors, they have good outcomes, but their costs and prices can only be afforded by the very affluent. And they want a credit card. As soon as you enter, the first thing they want is your credit card before they will do anything for you. So the attitudes here are a little different. Yes.
I was wondering if is there any parameters on who pays and who doesn't, or is it strictly honor system? And then is there partial pay, or
yes,
just people can give donations?
Correct. All of the above. When you walk in some of these hospitals like Arvind, you just say, I can't pay. There's another hospital that says, go left if you can't pay, go right if you can pay. And nobody checks. And they say, maybe 10% of the people lie, but most people they think who should be paying are paying. There's also partial payment. So in the heart hospital, they have people who pay fully, people who say, I can't afford to pay. Then they sit down with you, with a counselor, and say, so what can you pay? How much can you pay? They see if they can at least cover the variable costs. We're going to have to do this, we're going to have to put this tent, whatever it is. Can you at least cover that? Then they may eat the rest. And even to eat the rest, because it's a for-profit company, right, with shareholders, they have a foundation that will pick up the costs of the parts which are not covered. The foundation is funded by charitable contributions. So between a combination of fully paying, partially paying, totally free, but they also watch that on a daily basis that they are balancing the books. So they may say, we really can't take another free patient today. So if it's not an emergency procedure, can we schedule them next week, and so on. How are we doing on time?
We're close, but I think we have a little more time.
Can I do one more question?
Oh, okay. Yes.
Watching the cataract surgeries from one to the other, are the infection rates higher than the U.S.? I would think they would be.
I know. That's what I would have thought too. But they're saying that, if you notice, they don't scrub between procedures because that would waste time and would waste the gloves. They don't even change their gloves between patients. They take antiseptic, something you saw him do. If you saw, he does this. They're saying for this procedure, you don't need to do those other things because we're not getting complications, we're not getting infection rates. They're saying something about the eye. Maybe it's like another organ. If you're opening up, it may be a different story. But for this, and they've had doctors from the US, from the UK go study them, watch their procedures, check their infection rates to see if this is really true or they're fudging, because they don't have reporting standards like we do in the US. So can you believe these numbers? And so there are real expert doctors who have gone, and I'm not an expert, so I can't say I know it for a fact, but people who do seem to say that this this kind of procedure is safe. Now the point is, we don't need to go as far as they've gone. Our goal is not to get cataract surgeries down to $40. Our goal is to not let it go to $5,000 from $3,000. We need to only bend the cost curve. So we don't have to do everything the way they do it. We don't have to watch the second decimal. They watch every penny. Literally, they watch every penny. Because when you're operating when you're charging $100 instead of $1,000, you have motivation to take away $1 or even a couple of pennies. If you're charging $3,000, what's the incentive to save on pennies, right? So because they are so careful, they do things that we find shocking. But we don't have to do all of the things that they do. Can we, for instance, have more focused factories, as we call them, for procedures that are fairly straightforward? And that's what really the book was an attempt to see.
I was going to say the video
Yeah.
showing the patients with the cataracts, their cataracts were so bad
Yeah.
when they went.
Yeah.
Like we see an eye doctor before, and
Correct.
it tells you gotta wait. Yeah,
Yeah, most
that's kind
people,
of sad.
yeah, most of them, only 5% of people who need open heart surgery get it. So all of this is still fixing 5% of the problem. From 1%, maybe it's gone to 5%. 5 million people die of heart issues every year. So that's the scale of the problem.
Some of the high costs in the United States is due to the pharmaceutical companies.
Yeah.
How is that controlled in India?
Yeah, because they use generics wherever they can. Generics are very cheap. But the expensive ones, even the expensive ones, we pay the highest prices in the US. Even the on-patent drugs are priced differently in other countries, including Canada, as we all hear all the time. So their prices in India are lower than they are over here, and that helps.
Would you say our urgent care centers are sort of like spokes?
Yeah, they are. But they're not necessarily connected to the hubs. They're just independent spokes, right? So there's no optimization between, there's no telecommunication link, for instance. At the urgent clinic, you can't say, oh, in this case, let me just check with the expert, and I can have a way to go to an expert remotely in the hospital. So that integration we don't have.
One last question.
Yeah.
My wife, who's worked in many doctors' offices over the decades as a nurse in various capacities, has noticed that these practices that involve multiple doctors seem to have two brains. One is the doctors who supply the caring and the expertise, and managers who manage the practice, and they supply the means.
Yeah.
And her observation is, well, that works well sometimes. Sometimes they don't seem to be in sync. So this may require some cultural change or something. Any comment on that?
Yeah, that's why I was surprised that these hospitals that we selected after looking at like 60 different hospitals were almost without exception founded by doctors. And I think their imprint is still there, very strong in the running of these facilities. They have not scaled up the way we have scaled up hospitals here. We don't have huge national chains that own hundreds of hospitals and are trying to use scale as a way to negotiate with insurance companies rather than scale as a way to lower cost. And then pass it on to, because there's no incentive to pass it on to the, who do you pass it on to? You pass it on to the insurance companies, they may swallow will they pass it on to the patients or ultimately to the employers? So I think if they scaled up and they become much bigger, they may have to deal with those challenges too. Yeah.
Okay, well, that was really interesting and in some
Thank
areas
you.
kind of exciting.
Thank you.
Thank you.
Thank you.